Hello, I'm Dr. Ramsey Abadir at American Endovascular at our Fishkill location, and I'd like to present a critical limb ischemia case that we performed recently. The patient is an 80-year-old patient who I know quite well. We placed superior mesenteric artery stents and celiac artery stents, as well as bilateral iliac artery stents in the past. Currently, she's complaining of severe claudication and rest pain in the left lower extremity. She can only walk about 50 feet before the onset of really bad cramps and a burning sensation in the foot and calf. More ominously, she's also woken up at night with the same kind of calf and foot pain, suggesting rest pain. Her past medical history is significant for coronary artery disease. She's had 3 heart attacks. She also has a history of hypertension, peripheral vascular disease, diabetes, hypothyroidism, obesity, and she's a prior smoker. Currently, she's on antiplatelet therapy with Plavix. She is on rosuvastatin, as well as Zetia, levothyroxine, and metformin and Maxide. On physical examination, her left foot was cool to the touch compared to the right. She had an intact femoral pulse, but she had no popliteal or distal pulses. Her foot was mildly erythematous. No ulcerations were present. So our initial evaluation was to send her to the non-invasive vascular lab. And there we have images from the arterial duplex, which shows no flow in the superficial femoral artery, as well as the popliteal artery with damped monophasic flow seen in the in the perineal artery, suggestive of occlusion proximally. This is confirmed on the PVR study, which shows a severe reduction in her left ankle brachial index down to 0.38 and marked diminution of the waveforms below the level of the knee. So the patient has been maximized medically already with her statin therapy as well as her antiplatelet therapy. She's a poor candidate for surgery due to her comorbidities. So the decision was made to proceed with endovascular intervention to try and restore blood flow to the left leg and foot. She was brought to the interventional suite and an angiogram performed. Here are 2 images from the angiogram, which demonstrate occlusion of the superficial artery starting in the proximal 1/3 of the thigh, as well as occlusion of the popliteal artery. The only tibial vessels we see are reconstituted as isolated small vessels. The tibial perineal trunk giving rise to the origin of the posterior tibial artery, as well as the perineal artery, and a small attenuated anterior tibial artery. You can notice that there really is pretty poor collateralization around the knee, explaining the degree of her symptoms. Here are more detailed images of the circulation below the knee, again confirming isolated reconstitution of the tibial vessels. The posterior tibial artery then also occludes. The perineal artery continues, but it's small and irregular, as well as the anterior tibial artery. And there is a short segment focal occlusion of the anterior tibial artery as it crosses into the foot as the dorsalis pedis artery. So we proceeded to perform subintimal angioplasty through the occluded segments of the superficial femoral artery. And you can see several images from that procedure here with long segment angioplasty and restoration of flow. That was relatively insufficient to keep things open, and she required stents extending from the superficial femoral artery through the popliteal artery. The last panel depicts inline flow across the knee joint into the tibial perineal trunk and the perineal artery. We elected to proceed with as much revascularization as we could achieve during this procedure. So we then extended our subintimal angioplasty across the occluded segments of the anterior tibial artery proximally. And you can see here angioplasty being performed across the occluded proximal segment, as well as across that distal occlusion into the foot. The final pictures demonstrate an intact tibial bifurcation. The posterior tibial artery, we didn't feel necessary to revascularize, but you can see she has inline flow through the perineal artery to the foot. The dorsalis pedis artery was in spasm across the dorsum of the foot, but that later reconstituted. You can see here the results of the procedure on her 1-month follow-up. She had complete resolution of her rest pain and claudication. And if you compare the PVR studies before and after the procedure, you can see marked improvement in the waveforms throughout the left lower extremity, and normalization of her ankle brachial index up to 1.21. So this case demonstrates a percutaneous revascularization of long segment occlusions of the leg with very poor target vessels to reach. She's going to continue on with statins and dual antiplatelet therapy, and up till this point has remained completely asymptomatic. This is a good demonstration of how complex interventions are now feasible for distal vessel disease. We can cross long segment occlusions, and we have new tools on the forefront, such as optical coherent imaging, which is catheter-based and allows us to see the residual lumen of vessels and recanalize even longer segments. Thank you for your attention.